So, I'm Melanie Thomas, and this is my partner, Karen Morgan. We call each other our work wives.
Yeah.
So, the legs that did so much now need your help. Thanks, Ellie, for another riveting title. Because we don't know what we get. We just get the title, so we don't really know how we're going to fill it. But you'll soon find out. So, there's Karen and I with our, professional photographs with the Trini stuff on. So we said, actually, the legs that did so much now need your help so I can help myself. Because really, we've heard lots about person-centred care, we've heard lots about patient-centred care, individual care, but actually, patients have got to want to change. They've got to want to accept the help that we can give them. But also, us as professionals have to listen to understand what help they're actually asking for. And that's what we are going to talk about today. So what help can we provide, and to make sure it's the right help? So Lymphoedema Wales, we have 7 lymphedema services, and then we have a national team. The national team started off with Karen and I, and now the national team has 26 people in it. We've got over 130 people in Wales in lymphedema. So we're quite a large network. We're currently out to advert for our second psychologist, and we're also going to go out to advert for a dietitian, hot off the press. So we will be really, truly multidisciplinary, because then we will have nurses, physios, OTs, paramedics, psychologists, dietitians, and we bring in the doctors now and again when they need it. Sorry, doctors. But that's what we do. We work together. So that's lymphedema for you. And obviously, although we're talking about legs today, and 70% of our workload is bilateral legs, we also see other areas with lymphedema, which I will explain more about. Now in Wales, if you ever need to get money, you've got to use the terminology that will give you the money from the government, although there is no money at the moment. We are bankrupt, apparently. But value-based healthcare is something that they are pushing forward as the solution to the NHS. And I've got to say, we've always been value-based healthcare because everything that we do, we make sure that there is such a big value and we get the most for our pound. So whether that means I've got funding for an 8A, next time I won't do an 8A, I might have 3 band 4s. That's the type of thing that we do for skill mix to try and get more bodies in. But value-based healthcare is all about the quantity, the quality of what we do, the cost of what we do, but then what are the outcomes for the patient? And we always talk about, yes, a man will have his knee replacement done, his pain is a little bit better, but he can no longer roll on the floor with his grandchildren because he's had the knee replacement. So his actual patient-reported outcomes are poorer than his clinical reported outcomes. And I'll talk a little bit more about that now. So lymphedema, where we come from? Well, we actually started 1997. Lymphedema services were very ad hoc. 2009, we wrote a Welsh Government strategy. 2011, we had £1 million. And £1 million was a huge amount of money back in 2009, so we thought, when the prevalence of lymphedema was 2 per 1,000 people. The prevalence now is about 7 per 1,000 people. And it's growing year by year. As you can see there, we've got 23,000 people in Wales with lymphedema. So as time went on, we did lots of different things, and then we did a business case. And the man, I think at that time, I said, somebody's got to have money. Who's got money? And they said, oh, it's the Director General in Welsh Government. He's got money. Right, let's go and meet him then. So off we went, the Ant and Dec show, told him everything. And at the end, he turned to us and said, how much money do you want? And we were a bit like, oh. I said, 2 million. And he went, okay. And I was gutted. I thought I should have asked for 4. Bloody hell. And then he said, I like the way you present your data, but I think you should present it another way. And what did you say?
Well, I said, so we have focus groups, we have health economics, we have qualitative and quantitative. I will present it in my bikini if that's how we'll get the money. How else do you want us to present it? And I suppose as we go through the session, both of us are contactable, both of us share, okay, we're big sharers. Too much sometimes, but we do share. And what I'd say is, if you haven't got any data, which Mel will go on to, you haven't got a problem, okay? So like we've heard all morning about, we know that that's the NICE guidelines, that's what we should have, we haven't got it. How do you change that? It takes a lot of passion, but it also takes, you've got to have data, because otherwise you can forget it. So even if you start very small and you prove the value and worth in one area, then that can escalate. So you start, we talk about it as a little start, which becomes a tsunami of change. That's the only way that you will change things, okay? So don't think that where you work and the data you can collect is not important, because it absolutely is. And that's how we started. So, yeah.
Okay. So, and as you can see there, we did get 4 million. And then last year or the year before, we had another 1 million. So we've had quite a bit of money. We all know these consequences. They're there. And these are some patients that have just been referred to us in the last couple of weeks. But for me, when we're talking to people who hold the purse strings, we've got to talk their language. And that's something that I learned over time. So I talk about wasted resources, harm, variation. I could save you X amount of pound as long as we do it my way. And suddenly your accountants, your finance directors will start listening to you. Again, you can do it. I'm a physio, Karen's a nurse. If I can do it and Karen can do it, anybody can do it. There's nothing special about what we've done. It's just tenacity, a little bit of a maverick helps, but just getting out there.
The other thing as well is, if you can't get in the door, and you can't get in the back door, and you know it's right, then you get in the window. You get in there and you tell them, and that does take determination and it takes energy, but you know it's right, then that's what you do. And you don't stop shouting, because you are the people who have the patient's voice. And a bit like somebody said earlier about leg ulcers being a Cinderella service, or somebody mentioned that, you know, once it's gone, people aren't bothered about it. Lymphedema, unless it affects you, you're not really worried about it, are you? But if it affects you, then you are. So if you sort it, then you're not as passionate and driving that forward. But actually, we've got a brilliant patient advisory group, and we run with them because they're the people that have it. So actually, we are their voice, and we take them into our board meetings, and we take them to Welsh Government, and they speak and say how it affects them. For me, I will refer to a vascular consultant, I'll refer to a paediatrician, and that's anybody. There is no reason, if the treatment you're doing isn't making any difference, then you need someone else to see them. So whoever that is, it doesn't matter. And don't think your voice is loud, because it is. You are speaking on behalf of that patient. And I always think, if it was my mum, I'm sure all of you think like this, right? God help anybody if I come into the NHS. I try to wear compression. I'm got it on today. I wish I had, because my legs are cold. But I wear compression to protect myself from NHS, because once I become a patient, I probably would be a bit of a nightmare, if I'm honest. However, we are their voice. So if what we're doing isn't working, like all of the people that have spoken today, you are only within your area. You need to refer out. You need to get other people in. You can't keep doing the same thing, because you'll have the same results. You've got to change and collaborate. We collaborate with anybody and everybody, don't we?
We do. Okay, so these are all things that we would give to our patient for self-care. Compression garments, multi-lymphedema bandaging, self-bandaging, MLD, skincare, exercise, weight management, SLD, massage, advice, do's and don'ts. We burden all these things, we give them loads and loads of things, but do we think about what is the value? Should we be just giving one thing, talking it through, how it impacts their life? So if we look there about skincare, okay, we say wash, dry, moisturise your skin daily. What cream? Why do we do it? Well, we're doing it to reduce cellulitis, to reduce the risk of your limb getting bigger. But actually, think from a patient's point of view, the time it takes to moisturise and look after ourselves. We all know. We know we should moisturise our whole body. I bet we don't all do it. We do the face. But when they're doing it, it's a reminder of what they've been through. They've got to have the time to do it. Sometimes they don't like the feel of the skin, putting the cream on. They don't like the smell of it. You've got to have the function to do it. But it's all these things that we don't know really. So, self-management. Is it a burden? Is it a benefit? And where does value-based healthcare come in? So, we've heard lots again today about clinical reported outcome measures and what type of things are clinical reported outcome measures. So volume, range of movement, how many cellulitis episodes they've had. That's important for cost. How was their wound? How long they've had their wound? How many other professionals have been involved in their care in the previous 6 months? And you can cost that out, do a new intervention and then recost it. And that's when the finance directors will give you money. Looking at pain, looking at quality of life. So those are your clinical ones. But from a patient, is it cancer? Can I have a pedicure? Can I go swimming? I want to play golf, is that all right? I'm really scared of having a cellulitis. Can you stop the horrible smell? I want to go on holiday again. I want to feel intimate and desirable again. Those are the real outcomes for patients that we see. And then you've got FROMS. FROMS is not a swear word. Anybody know what FROMS is? Family reported outcome measures. This is the big thing that's coming in from Welsh Government. So, which service is going to be the first in Wales to do it? We are. Why? Because he'll give us some money. And it's quite easy. And he'll improve. So a FROM is, I'm a patient. No, we don't spend the money. I'm the patient. My husband is looking after me. What is the impact of my disability on his life? That is a FROM. And how can we improve it? So then we can look at things as to the carer's burden and we'll have evidence to prove it. So all that type of thing is why it's an individual approach. So in Wales, we created Lymprom. We've published one paper, the final validation paper will be out, it's meant to be December. Fingers crossed it's December. But this is Lymprom. It's got 13 items. It's got physical, emotional and functional. And it was quite interesting. I heard somebody talk about the outcomes earlier. And we captured this from patients, what they wanted their outcomes to be, not what we wanted them to be. So in Wales now, we've actually got a dashboard. So how it works is you come to an appointment with us, 2 weeks before your appointment, you get a text or you get an email, please fill in your patient-reported outcome. And the patients fill it in. So we've had nearly 20,000 PROMs in. What do you think the biggest problem is with our patients? Oh, I was nearly showed you then. So you've got home life, work, personal care, finances, body image, intimacy, desirability, walking, anxiety, hobbies, holidays, shopping for clothes, pain or heaviness. Shopping for clothes and shoes. How many of us discuss that with patients? Some do, brilliant. I've got a leaflet for everything. Have I got a leaflet for shopping for clothes and shoes? No, I haven't. We will have shortly. So within our dashboard, I can put in which area in Wales it's from. So we can look at population health. We can look at are they male, female, or they don't want to tell us, where their lymphedema is, and then we can come by different responses and you can see their ages and so on. So there's some of the big things. Heaviness, 5.7 out of 10. Pain, 6.2, shopping for clothes and shoes. Now when you go into the area there, you'll see just for the leg and the foot, suddenly walking and shopping for shoes are the highest on the physical things. When you then look at the softer ones, which we think would be softer, intimacy, desirability, body image, they're 7 out of 10. Would you think that? Would you think that somebody who's got a lower limb problem, that body image would be 7 out of 10? Wouldn't you think that that would be more like our breast cancer patients? It's not. It's all of them. So again, it's back to how can we help you? We can't help you unless we know what your problems are. So these are 6 people that have been referred to you today. Every single one is urgent. So the first one with the stockings on. Do you think that's urgent? Could be. Maybe. Out of the, which do you think is the urgentest?
Yeah,
Exactly.
important point.
But are they? Wait and see. So what did the patient want? What did the referrer say that the patient wanted? But is it value? Is it sustainable for our service? I.e., we can't see all of these urgent patients today. So patient 1, I don't know why I've been referred, my legs have been like this for 20 years. In fact, the swelling's better. Is it urgent? It's not urgent to that patient. I feel suicidal. I can't use the toilet, everyone laughs at me. I hate my arm, I'm in so much pain, help me. What referral? It's only a little bit of edema, doesn't bother me. And that is somebody with a large swelling. The next one, I don't want to be seen, leave me alone. I need new stockings. So suddenly it makes you start thinking about, we only know what's in that referral that comes into us in a paper or an electronic way. How can we really find out from patients now what is the true story? So lots of those patients with DNA, these are our DNA rates, and this is a paper that has been published, I think it was in the summer. If I haven't put the reference there, but if you want it, it's there. It's DNA rates in Lymphoedema Wales. So this is the new patient model, and this is starting in Wales. So you refer a patient to us, our administrator rings that patient up within 3 days to say, we're sending you a PROM, please fill in the PROM. You will then receive a virtual consultation within 10 days from a qualified, registered, or an unregistered profession working at the top of their licence. Based on that 30-minute telephone conversation, we will then arrange what is valuable to that patient to see them face to face. Why do you think we're doing it? Well, actually, we're doing it because it's the most economical way. It is the best way that we can see patients in the right place, right time by the right professional. But also, we're seeing the urgent patients sooner than just having 6 urgent referrals. And we'll tell you much more about that hopefully next time. And there's the costings. So I'm going to pass over to Karen now, and we're going to tell you about one scheme that's going on in Wales.
So I mentioned earlier that if you keep doing the same thing, you get the same results. So you have to be we have to be proactive. We're very reactive. Can you hear me? I've got quite a loud voice anyway, okay. So, but we have to think proactively. So when someone says to me that little bit of edema, doesn't really matter, Karen, you know, my head does a 360 so quick that you don't see it. So that's like telling me, well, that's a little bit of diabetes. Let's just leave it there now and see how the patient goes. The sooner you help them or work with the patient to manage that, the better. So how can we go and get patients? So we're not waiting for them to come in. We're going to find them, okay? Those of you who know me, I'm looking at everyone's legs all the time. Or my daughter's grown up in lymphedema with me, and honest to God, she says to me, look at them legs, ma'am, I think they need to see you. I'm off today, retiring next year, might come back for a couple of days because I've still got a bit of passion in me, but I'm only going to look at everybody's head, just to let you all know, okay? If anybody believes that, it's not true, but anyway. So we put a bid in for a National Cellulitis Improvement Programme. You will know that there's a link between cellulitis and lymphedema. You're at risk if you have lymphedema of developing cellulitis because of the protein-rich fluid. You're also at risk of developing lymphedema if you have lots of episodes of cellulitis. So there is a link, okay? So we thought, well, how can we go and get these patients earlier? Now, we are very fortunate in Wales because we have lymphedema services everywhere. The only way that we've got lymphedema services everywhere is because we have demonstrated the value of having them and with the data. Okay, so if you haven't got a lymphedema service, you need to tap into us and see how you can create that, because for us, we don't want to be the last resort. I don't want to have patients referred to me with complex wounds, legs that have been swollen for years and years and nobody's seen them. So the Cellulitis Improvement Programme is very much going to get them. So every patient that was admitted through hospitals in Wales that had a diagnosis of cellulitis, some of them we would argue weren't cellulitis, but we'll park that for a minute, we invite them to come and see us. So it's a go get in them. Okay, it's proactive. And we're just going to show you some of the information that we've captured from there. So basically, we send every one of those patients that's been admitted a reducing the risk leaflet. So even if they don't come into us, they have some information, okay? A lot of them want to come and see us. So the next one just talks to you about the background. I'm conscious of time, so you can have the slides, it's absolutely fine. But you can look at the GP events, you can look at the effect, you can look at the amount of people that have cellulitis. This is a massive cost to the NHS. If you can reduce that cost, you can have a bit of that money to have another service developed here. That's the way you've got to think, okay? Think of it like you're budgeting your own budget in the house. You know, if I can't have this month, if I buy this month, I can't have that. That's exactly what we're talking about. And the NHS is broke. So it's all of our responsibilities to save some money, okay? Because it needs to be there for when we need it. So the cellulitis improvement started right in the middle of COVID. It's still continued. And you can see that we've got 3,500 episodes of completed care. But we've actually invited 23,000 people. So the completed care is they're seen once, they're reviewed, and then they're discharged or referred on to whatever service they need to be referred on to. So what on the activity of the 3,500 people? Well, you can see the male-female breakdown. You can see the vulnerability scores, the frailty scores. You can see we're an older population, ageing population. You can see the impact of who is most affecting. There will be papers written about this as well, and I do feel like we're talking like we're on speed here because I'm going really quick. But of those, I do talk like that. I'm really sorry. And I'm kind of like the sugar rush is hitting in now after lunch, so I'm even quicker than I normally am. But that's okay. So I feel like I'm regurgitating it all onto you. So you can see here what those patients had, okay? So lower limb, 71%. What are the comorbidities? We've talked about that. The blood pressure. Why is blood pressure important? What does amlodipine do to your legs, your arms? Yeah. So why is that? So is there an alternative? Or do they need to be on that? Or do we explain to that patient that actually your risk is a little bit higher because of the medication that you're on? Do we manage that? Do we palliatively manage that? You can see the vascular, you can see the fungal infections, you can see all of the things that we are able to capture with the data. And like I said at the beginning, no data, no problem, I used to say, but Mel now includes no solution, and that's absolutely fine, it is. Lymphedema is a risk factor, as you know. And you can see we're now working with, I think the next slide, we're working out with phase 2. So we've done the patients that go through ED, but what about all the patients in the GP surgeries? What about all the patients you see that are on antibiotics? And nobody, Rebecca talked about stewardship, resistance. Are they appropriately treated? So actually we need to be looking at why they might have cellulitis, or actually they didn't have it and they need compression or they need to be seen by other people. So you can see we've done a lot of work around prophylaxis. We link in with antimicrobial pharmacists, microbiologists. Like I said to you at the beginning, we collaborate with anybody and everybody. Celluprom, you would imagine, if we have a problem for lymphedema, well, there wasn't one for cellulitis, so do you know what? We'll create one then. We don't want to reinvent the wheel, but if there isn't anything out there that's working for you, then perhaps you do need to look at what you need to create. So it's the same, what pre our intervention and post our intervention. And you would imagine, quite rightly so, the fear factor is the biggest outcome here for patients. If you've had a cellulitis, you are fearful of it happening again. If you've had a sepsis, if you've been admitted to hospital, you will do everything in your power to reduce that risk for you. And that's where this service comes in. Is that it?
No, but that's not how worse, is it?
No. Well, that's it.
Well,
there we are then. So, I'm like, yeah. Oh, okay.
The only other, just one more thing. The only other thing I was going to say, they've taken some of our slides. They obviously think we've done enough, but that's fine. Or you sent the wrong one.
My fault.
Their fault. But anyway, so with that cellulitis programme, we've actually avoided, not spent, whatever other word they say, because you're not allowed to say saved. Basically, it's something like £14 million in a year because of the cellulitis programme. So it is worthwhile. The other thing just to add is how can we help you? 21% of our patients have a mental health diagnosis in lymphedema services in Wales. We've managed to get funding because we've done LymProm. We've managed now to get a consultant psychologist, and we're just interviewing for the second psychologist. So it is a good service. But to go back, lastly, share decisions, listen to the patients, work together, co-production, and actually find out what their needs are rather than what we think their needs are. Thank you.
Yeah.
You can't get it.